Yeah, good afternoon, and I'm very happy to talk to you today and want to just share some experience from my side with you. So I'm a human geneticist by education, and I think one thing that we discussed already, and I just want to say this in the beginning, I completely think that the data belongs to the patient. We have a gene diagnostics law in Germany, and whenever the patient says he agrees that the data can be scientifically used, we share the data. I'm submitting my data to ClinVar. I think it's a very good database, and hopefully I think that many others are submitting as well. And my belief is that the companies who are not sharing data, they will not survive in the future if we all go this path. This is the disclaimer and disclosure, though I'm going to tell you my opinion and not the one of Illumina. And I just want to tell you a little bit of my own way. I came to human genetics by identifying mutations within the LARC2 gene a very long time ago, and that fascinated me in a way that I didn't want to do anything else. And LARC2 is a very large gene, has 51 exons, and I spent lots of time sequencing with Sanger sequencing, and when next generation sequencing came around, I just wanted to use this new technology, and so this is one of the reasons also why I funded the company CeGaT. I'm located in Tübingen, southern part of Germany, and we are now almost 150 people working there, and I think that's something which is good in Tübingen because the university is there. We have specialists in bioinformatics and many others, and so at the moment I think the focus of the company is also quality, and I think this is what we heard about here today is what type of data do we collect? And I think this is very important, and I want to bring this up during my talk. So I have CAP and CLIA accreditation, and unfortunately in Germany there are so many different laboratories using so many different strategies, and I think Germany is particularly a problem since there are no rules, no standardization, no processes that are common for all the laboratories, and I think this is very important that we have to think about it if we want to analyze the data in the future. At the moment, or at least in 2018, we are expecting to analyze approximately 15,000 patients, so it's quite a number already. So our focus is to find the genetic cause of the disease, and we are doing the sequencing in-house, the bioinformatic analysis, and the medical interpretation, and we are giving out the report. So that's basically it. I'm coming from a totally different perspective, and I want to just share some things that I think is important, and just from my perspective. Every human is unique, and every disease is unique, and we have to take this into account when we think about precision medicine in the future. This is something I've been struggling with as a human geneticist the last years, because human genetics usually is not implemented in the beginning. When a patient comes to the clinic, you do a lot of diagnostic tests, invasive tests, but you don't think about genetic testing in the first place because it was so extremely expensive. And now I think we come to a point, and this is something, at least this is my vision, that human geneticists really become part of the clinical routine. So we want to be part of treating the patient, and we want to make clear that genetic testing has to come first and then therapy. So we need to be an integral part of the clinical routine, and I think this is something we are trying to do at the moment. Today, as you know, for many diseases, we test for frequent genetic variants, and then sometimes we have a therapy, but most often we don't. But in the future, and this is a most frequently shown picture, I think, is that we think that every individual is so individual that we need individual therapy in the end. The technical revolution, I don't have to talk about this in detail, but it enables us to do genetic testing in very, very short time. So when the patient comes and we get the blood, you get the result ideally now within 4 weeks, but hopefully soon also within 2 or 3 weeks. But still we need time, we need to prepare the DNA, we need to do enrichment, and I come to this later, and then we need to write the report and do the interpretation. We have many different diagnostic methods available at the moment, and I think the human geneticist is, well, at least this is how I see it, is a part in an interdisciplinary team. We have to also think about which method to use, and also we have to think about which tissue to use. And when the patient comes, they often say, I want to have my genome sequenced, but is the genome really the right tool at the moment? I think for research setting, yes, but in a clinical setting, I wouldn't say so. Why is that? This is an old publication from 2016, and it's on cardiomyopathies. It shows you that if you do whole genome or whole exome sequencing, everything that's red, that is maybe not covered well enough. And especially with cardiomyopathies, you have T-gene, which is a large gene. You have many other genes that are very difficult to sequence. And this is something we have to keep in mind, that for many diseases, whole genome sequencing is maybe not deep enough. So if we look at whole genome sequencing at the moment in a clinical routine, you would maybe get 30 or 70x coverage. It's still not cost efficient. You get large amount of data that you cannot interpret. You will not detect mosaicism, but I think it's a very good tool for research. Then we have whole exome sequencing, where we focus on the coding part of the genome, enriching the 23,000 genes. It's a very efficient screening method. You have to deal with incidental findings. And there is another approach, which is the panel sequencing approach, where you achieve really high coverage per base. It's time and cost efficient. You almost have no incidental findings. You detect mosaicism, but you frequently have to do updates. And from the technical point of view, I don't know, most of you are maybe aware of it, genome sequencing actually is the easiest thing to do. Genome sequencing, you fragment the genome, you put it on the sequencer, and you get the data. Panel sequencing actually is a huge effort. You have to design debates, you have to enrich for the genome parts that are relevant for the clinic. So it's really a lot more to do, and a lot. It's a much bigger effort, but I think much more efficient in the end. This all has nothing to do with dementia now, but I will come back to dementia in the end. And I just want to give you a little bit an overview on my journey and why I think this, what I learned at least in the last year, is maybe important also to translate into the neurodegenerative field, where I think we are not doing good advances at the moment in the clinic. This is a patient with epilepsy, and we sequenced an epilepsy panel with very high coverage, and it's a 9-month-old female. And what we found is an 8% mosaicism for a gene called GRIN1. You would have never found this with whole genome, with whole exome, let alone Sanger sequencing. And this is actually something very frequent from the clinical routine. And if I think about neurodegenerative diseases, and especially parts of the brain that are affected by maybe mutations that are not present in all neurons, we would never detect it in blood, and we would never detect it with whole genome sequencing at the moment. Trio exome diagnostics is a very, very efficient tool, and I think I do not have to mention this in this audience, that from the clinical point of view, a single exome does not make any sense any longer. As long as we can get trios, especially, you know, the publications also for ALS, trio exome sequencing is very powerful to identify de novo mutations. Also, if the parents are carriers, it's fast, and there's no technique that's more efficient than trio exome diagnostics at the moment, if the genes of interest for a specific phenotype are not known. I will jump over this and just will give you a view on how in a clinical setting exome diagnostic looks at the moment. When you do the sequencing, that goes very fast. You enrich for the exome, you have the sequencing data ready, and then you start with the analysis. And here you can find many differences in many laboratories, and there's no standardization. And this is why I think it's so important, and also how we, the data quality we generate, the data quality we deposit, and how we analyze the data. You can analyze an an exome, a trio, for example, if you look first for de novo variants, then you look for homozygous, compound heterozygous, you look for X-linked inheritance, and then, very importantly, look also for deletions. And this is not frequently done, but I think it plays a huge role, especially also the small as well as the large deletions. Then, still in the exome, you can look for mosaicism. It's difficult, but if you adapt your filtering, you can still look for mosaics. You can look for loss of heterozygosity. You can look at a mitochondrial DNA. And if everything is negative, then you still have tools to look in more depth. For example, if you have a list of candidate genes and you find only one mutation, you can look more specifically. And this is only an example where I want to mention that geneticists can never by themselves solve this if there's no clinician at our side. Here, this is a patient where the clinical suspicion was so strong, but we could not identify it by whole exome sequencing and neither by panel sequencing. And what did we do? We had to go to a different tissue. So you see on one side you see blood on the left side, and in blood we were not able to detect the mutation. But once we did a buccal swab, and then we were able to see it. And I think especially for brain diseases we have to think about using a different tissue. Blood might not be a good way to sequence and to generate lots of data. It might be more important to maybe think about a different tissue for all the patients you are collecting. Another patient where we, so from, I think the clinical picture is not so important, but I just want to show you the principle here. But this patient has had chronic diarrhea, malabsorption, metabolic acidosis, trio exome sequencing was negative, mitochondrial DNA was negative, everything we did was negative, and then we did a custom panel. So we said, well, these are candidate genes, we might have to look in more detail, and then we only found one mutation but didn't find the second one, and the one couldn't explain it. But only if we looked in many, many more detail, we found a little deletion that explained the second, then explained the recessive inheritance. And if you just have computer programs running over your data, you might miss these little things, and especially small indels, small deletions are still very difficult to find. And I think here, genome sequencing will help us dramatically to improve this. The last part, I'm going to focus on tumor diagnostics. And again, here I learned a lot, and I hopefully will be able to bring this back to my thinking how we can maybe improve the situation in a clinical setting for dementia. But I just want to walk you through this. I do not know how many of you are familiar with this. I'm just now telling you this because most of my patients I'm seeing are actually tumor patients, and this is how the clinical reality looks like at the moment. And I think this interdisciplinary approach that we have here, I don't know how you have implemented in your life already, but I think it's very good. The patient is still in the middle when it comes to treatment decision, but you have many specialists sitting around the table, and genetics is just one little piece in the puzzle. If we think about precision medicine, we have to become much more precise in diagnostics. And genetics, as I said, is only a little piece, and the genome, the epigenome, the transcriptome, microRNA, whatever is to come, then the whole chapter of pharmacogenetics, I think, is going to be very important. And here also, the pharmacogenetic relevant genes are very difficult to sequence. They are highly homologous, and it's really hard to capture all variants that are present in these genes. Then we have to advance computational pathology in the same time, like molecular imaging. And I will come to a part which I think is very important, which is the immunology and also the microbiome. And I think this is also important especially for dementia in the end. The tumors are all genetic. I'm not talking about hereditary tumors at this point. It's the tumor itself. The tumor is tumor because of genetic variation, and every tumor is different because it contains different mutations. And here you see TP53, this is the most frequently found tumor gene, but many others. And this, I don't know if you have seen this slide before, is one of the most frequently shown slides, and it's highly interesting because it shows you that it's not only important which mutations are driving a tumor, but it's important how many mutations the cell contains. And there are tumor cells that only contain very little mutations, but there are tumors that contain a high number of mutations. For example, the malignant melanomas, which you can see on the far right hand. It has, on the scale is the number of mutations per megabase in the genome, and then you see all the different tumor entities. Malignant melanomas contain up to hundreds, thousands of mutations in the genome, and there are other tumors like pilocytic astrocytomas in children that have only very little mutation. And this, what we call the tumor mutational burden, is very relevant with respect to the immune system. And all these small dots that you can see there are all individual patients, meaning that the diagnosis itself is not so important if the patient has breast cancer or prostate cancer, but it depends how the tumor looks like, if it has little mutations or many mutations, because this is strongly relevant for the therapy. I think that tumors are signalopathies, and why I became so interested in tumor biology is because I worked on LRRK2 for, I think, very many years, and the pathways that Parkinson genes are involved in are actually the same. Lots of Parkinson genes are actually oncogenes or tumor suppressor genes. Think of Parkin, for example, and I'm convinced that LRRK2 is a tumor suppressor as well. And it's the connection between cancers and neurodegeneration fascinates me, I think, like many others. And so understanding tumor biology might also bring us back to neurodegeneration in the end. Another aspect of tumors is the subclonality. And I think that what we learn here, we might also come back to the brain as looking as the brain being also a mosaic. If we want to detect mosaicism, we need to sequence very, very deep. Otherwise, we will not detect the mutations that are relevant for the therapy in the end. Again, I think I don't need to go here into detail, but if we sequence a tumor, for example, we will never go below coverage of 1,000 because it will not be helpful in the end. There's a shift in thinking. The pathologist world and the oncologist world was that if you have a specific entity, you have a name like lung cancer, breast cancer, then you look specifically for a subset of genes. This totally does not make any sense, because it doesn't matter where the tumor originated from or where it's now localized, because what you have to treat is the disease, which is usually a metastasized disease. So looking at many genes in parallel makes totally more sense compared to only looking at a few genes. And this not only helps you to identify the major drivers that can be the same that you know from breast cancer and pancreatic cancer or in prostate cancer, but it also tells you the number of mutations of the individual cell. If you say, for example, that breast cancer usually does not have a lot of mutation, it cannot be true maybe in the individual patient. How does tumor sequencing look like in a clinical routine? And here actually we are part of the clinical routine. The patient comes to my practice, I do the informed consent, so the patient agrees to do the genetic testing, and then we take the blood, we take the tumor. The tumor can be from surgery or can be a liquid biopsy. I come back to this a little bit at the end. Can also be a biopsy from the tumor itself, and then we sequence both in parallel, the normal and the tumor tissue, and then it's a bioinformatic part where you just compare the same genome of the patient with its tumor, and then you identify the mutations that are only present in the tumor. Then you have the mutational load, the total number of the mutations, and also the drivers. And then you can make a treatment decision. And here it clearly affects patients. Like you have a patient that has had all conventional treatment already, and there's no more therapy available for this particular patient, and then comes the sequencing, and then comes a treatment decision, and most often it's what we are now aware of, which is called checkpoint inhibition. I will show you the concept in the next image. Checkpoint inhibitors actually work very well when tumors have many mutations, and if they have only few mutations affecting one particular pathway, targeted therapies are a very good approach, because then you can inhibit the pathway or deactivate a protein that's activated. But what do we do with all the patients in the middle? And the majority of patients are actually somewhere in the middle. And here it's also, like I said in the beginning, it's a very unique situation. You have to have a strategy that's unique to every single patient. Checkpoint inhibition is a fascinating concept. If you have a tumor cell, you see it on the left side. If this tumor cell has many mutations in the tumor genome, then the likelihood that this mutation is presented on the surface of the tumor cell is very high as well. So through an individual MHC complex, a mutated peptide is actually sitting on the tumor surface and could be recognized by the T cell. The T cells, they are in the body all over the place. They are looking for foreign and self. They look for bacteria. They look for viruses. They should recognize a tumor cell if it looks different. But what happens here is that through a mechanism, at a point that is called checkpoint in the literature, the tumor cell actually tells the T cell, you can go away, I'm self. And this is something that's fatal for the patient, because the tumor can develop without being recognized by the immune system. And this has been a breakthrough in cancer therapy, when it was realized that antibodies that inhibit this checkpoint break up this interaction, and by this enable the T cells to recognize the tumor cell as foreign. And this concept works for patients that have many mutations in their tumor genomes, for example, malignant melanomas, for example, lung cancer from patients that smoke a lot. They have lots of mutations in their tumor cells. But there are many other patients with other tumor entities that can benefit from checkpoint inhibition as well, once you know from the sequence that the tumor has lots of mutations. And now, what do we do with all the patients that are somehow in the middle, where the tumor has not many, but also has not little mutations? But what do we do here? And here we come to a really part of what I think is really precision medicine is the tumor vaccinations. Vaccination has also been a big thing in the dementia world, but here in the tumor world, it really is highly successful. And the concept is as follows. If you know the tumor sequence, you can at least predict which of the mutations most likely appear on the surface of the tumor cell. And based on this knowledge, you can design personalized vaccines. You can do this with 4 different ways, actually. You can use an RNA-based vaccine, so you synthesize an RNA containing the mutation. You can synthesize a peptide. Peptides can be like 8 to 18 amino acids long, containing the tumor-specific mutations in the middle. And you can also take out the dendritic cells of the patient, culture them, bring them in contact with the tumor mutations, and then re-transfer them to the patient once they recognize the tumor-specific mutations. Or the so-called T-cell transfer, where you train patient-specific T cells outside the body to recognize the tumor, and then you transfer the T cells. Fascinating methods, very, very highly personalized approaches. For example, in the case of a personalized peptide vaccine, how does this look like? You take the tumor tissue, you take the normal tissue, you sequence, like I mentioned before. You do the analysis, so you predict the HLA type of this patient and how likely it will be that a particular mutation is going to be sitting on the tumor surface. Then you synthesize these peptides. You inject the peptides in the skin, like intradermally, and with an adjuvant, you attract dendritic cells in the skin. These dendritic cells come, they pick up the mutated peptides, and then you can generate a CD4 or CD8 T-cell response in this patient, completely avoiding the checkpoint and just generating CD4, CD8 T cells that recognize the tumor in the end. And then you have this very personalized situation where the patient has a vaccine that's generated against its tumor. How can we monitor that this concept is working? This is one question. The other question is, independent of the vaccine, if the patient gets a therapy, how can we monitor that this therapy is working? It can be a targeted therapy, it can be checkpoint inhibition. And then once the patient is tumor-free, how can we find out that the tumor is coming back? How can we see this very early? And then you can go one step further and can look at healthy individuals and ask the question, do you already have a tumor inside your body, and how can we detect this? How can we find this using genetic methods? And this is something where we have lots of advances at the moment. You find this in all the newspapers and also in scientific journals, is the concept of cell-free DNA. The concept of cell-free DNA is as follows. You can have either a tumor, or it also is, you know this from the non-invasive prenatal testing. It's the same concept. You have the fetus, and it's releasing its DNA into the maternal blood. The tumor is releasing its DNA in the blood, and we do nothing else. And this is the cell-free DNA that we can capture from blood. We sequence with very, very high coverage, and here you have to go even much higher than 1,000 times, because the amount of cell-free DNA that's specific to tumor cells or to the fetus is so small in the blood that you need to sequence really, really deep. But then what you end up with is you can either characterize the fetus from maternal blood, or you can sequence the tumor from the blood. And this is all we need to know. We need to know the mutations that are specific to the tumor in any stage of the disease to find out what treatment we need. And then, based on this information, we can design a targeted therapy. How can we use this information for neurodegenerative diseases? And what I would do, I would use the CSF. I would not sequence from blood. I would sequence from CSF, for example, and use this data, because what I would think is if you're losing neurons at any stage in neurodegenerative diseases, you would lose neurons. I mean, this is what we think. Once neurons degenerate or degrade or undergo apoptosis, they would release DNA, could be mitochondrial, could be genomic, could be RNA into the CSF, for example, also in the blood. And then we would sequence from there, maybe having this concept in mind. But here, as you can imagine, genome sequencing would not help you at all, let alone exome sequencing, because it's never deep enough. So I think from my perspective, at least from my clinical perspective, every human is different, and we have to completely rethink also clinical studies, because there are no homogeneous groups. We always try to stratify, we always try to put patients into groups, we try to understand concepts, but in the end, and this is what I learned from the tumor field, is that it's so individual that we really have N of one medicine in the end. And I think we have to think about concepts, how to implement this. Back to dementia, and I think at least this is what I feel, I have to go a step back, because we are far away from what I just presented to you with respect to tumor patients. This I already mentioned. I would do this. I would try to do that in order to collect data and to see if, when I do genetic testing for neurodegenerative diseases, so I'm sequencing to find patients to recruit for GenFi, for the DIAN network. So we do lots of testing for neurodegenerative diseases, but we find the disease cause only in a small minority of cases. I would say from our data, maybe in 20%. So the large amount of patients where we really think it is or might be genetic, we do not find the cause. We have to think about other ways to find the mutation. Then, and this is what I think, we have to collect data at the same time, because I think the microbiome, if we look at one human being, the majority of the genomes that we consist of is actually microbiome. and not human. And I think it always is already obvious that the microbiome is going to be so relevant for diseases that we need to collect this data as well at the same time. It's actually very easy and also by far not as expensive as sequencing the human genome, but we have to learn a lot and we have to collect this data now and not years later. Pharmacogenetics, I've been mentioning this in the beginning, but what I think is something we have to keep in mind as well is the immune system. And so I'm a human geneticist, but I think the genome is just too small information in order to understand the complexity of one human being. And only with sequencing the genome, we will not be able to go the next step to precision medicine. I think immune monitoring is something that's so easy to be done, but it's not done yet. And you can monitor CD4 cells, CD8 cells, cytokines, and in a clinical routine, I think we need to think about this. We have to implement these methods, and then we can maybe go the next step also with respect to neurodegenerative diseases. Thank you very much.
So there's a lot of excitement about prions and prion-like events in neurodegeneration. And some of us refer to as the prionization of neurodegeneration, but obviously somatic mutations could lead to misfolding events, which then lead to templating and disease spreading throughout the brain. Has anybody found any evidence ever that there's a protein sequence change in these patients that might be on the basis of a somatic mutation such as you're searching for? I didn't think there was, but you might expect that some of these analytical methods might detect something like that.
I'm not aware, maybe the audience.
No, I'm skeptical about it as an origin of disease as well, but I wonder whether anybody else agreed with that.
Thank you. It was a wonderful talk. The microbiome, is that, you think, a causal factor? And how is it wise to study that still at the diagnostic phase? Because a lot of patients lose weight, and we know that your BMI will determine your microbiome. So it's a very complicated factor to take into account in terms of diagnostics. So I would more look at it as a risk factor or determinant of disease or predictor of future disease.
I think in the first place we need to sequence it and see how it looks like. And I think you have to also here sequence regularly in the course of the disease. So you take the microbiome maybe every 4 weeks for 2 years, 3 years, and then you have to observe the changes during the disease, because I think the microbiome might be highly relevant with respect to the interaction with the immune cells, and the immune cells might again then react with the neurons. So we need to, I think we have to look at this whole circle and try to better understand it.
So you think it's also relevant for prognosis and how the disease develops further after diagnosis?
Well, I do not know yet, but I'm just recommending to apply for grants and to sequence it, and to not only, this morning we only talked about genome, variants in the genome, and I just want to point out that this is not going to be the whole story.
I agree. Because we're working at it in Rotterdam study quite extensively, and if you do the cheapest sequencing 16S, it's very quick and dirty, almost an array-like sequencing. That's not expensive. That's
it's €100 for 16S and €500 maybe for shotgun sequencing of the whole microbiome.
And I know that there are people developing arrays also. So there will be, I think Illumina almost, but I think there will be arrays around within soon. That's the prediction.
But it has to be
16S sequencing is very easy, and
It's easier from the sequencing point of view, but the pre-analytical steps are very critical. And the collecting of material and how you sample it, how long you store it, at what temperature you store it is very critical. And I think here, before we start also collecting lots of data, we have to think about standardizing procedures as well.
Hello, thank you. Such a great talk. I think both your talk and Sean's this morning really highlighted, the power and potential of looking at all the other omes, looking at different samples, circulating cell-free DNA and so on, and bringing this together with the genomic information. For me, it's just mind-boggling, and just, as an analytical challenge, how would you go about not just amalgamating all that information, but trying to draw some insight from all these different layers of complex omic data sets?
With cell-free DNA, I would say it's rather simple. I would first try to find mutations that I haven't found with sequencing blood. I can imagine that, for example, we find alpha-synuclein or LAG2 mutations or other mutations in a somatic state that we would not detect from blood. And then it's just a simple yes or no question. You look with very high sensitivity for mutations you would expect in tumors. You look maybe for TP53 or BRCA mutations or whatever. And in neurodegenerative disease, you look for the other known mutations. And this is, I think, I'm not aware if anyone has done it yet, but I would almost be sure that we just find a subset of patients that are just mosaics for specific mutations, also for mitochondrial deletion. It has been published already. But we are still just collecting blood and blood and blood and are not moving really forward.